Good evening, everyone, and welcome to yet another spotlight session of our series Think Beyond Sugar, brought to you by ISW Council and supported by Boehringer Ingelheim. I'm Resham, your host for today's insightful discussion on managing type 1 diabetes in children. We are privileged to have with us the two esteemed experts today, Dr. Sunil Gupta, who's a senior diabetologist and managing director at Sunil Diabetes Care and Research Center, and Dr. Archana, a consultant diabetologist and founder of UDAN, an NGO for underprivileged children with diabetes. So, our today's session aligns perfectly with the ethos of Think Beyond Sugar, as we aim to do more than just share facts and proper information. Our goal is to deepen our understanding of type 1 diabetes, particularly in children, and explore the comprehensive ways to manage it effectively. So let's start and understand how we can manage type 1 diabetes in children. Firstly, thank you, doctor, for joining us. My first question is to Dr. Sunil that when a family first finds out that their child has type 1 diabetes, what kind of challenges do they usually face, and what advice would you like to give them to handle these particular challenges?
See, it is always a kind of big trauma to the family when it is diagnosed for the first time. And almost 70, 88, sometimes 90% of the time, these family may not have any family history of diabetes. That becomes a another new thing. So diabetes comes as a first D in life, something which has just appeared, and it is very difficult for them to accept it because type 1 diabetes is not like type 2 diabetes. Type 2 diabetes takes time. It is in the pre-diabetes state for years together. Then you have
So diabetes
early
comes
stage
as
of
a first
diabetes.
D
You're
in
only on
life,
diet
something
therapy,
which
and
is
then
just
you're
the
on
pre-diabetes state
tablet
for
and then
years
insulin. So it
together.
is a long
Then you have
process.
a so
But
diabetes
type
comes
1
as a
diabetes
first D
comes,
in
you're
life,
on diet
something
therapy,
which
and
is
then
just
you're
the
on
pre-diabetes
very
state.
acute time. Maybe sometimes it comes in some with the history of 7 days, 10 days. Sometimes it's a month or so. बच्चा को दूध बच्चा बच्चा पेशाब कर रहा है, बेड वेटिंग कर रहा है, they might ask you, they might come to you with कि he has lot of hunger, बहुत ज्यादा प्यास लग रही है, बहुत ज्यादा भूख लग रही है, बहुत ज्यादा यूरिन कर रहा है. So these are the common symptoms there, and sometimes they have some infection not getting control. Weight loss. So the some so and weight loss is one of the very important feature. So these are few of the common symptoms they come to, and then the patient, the family is sometimes they say there's no one in the family, neither the parents nor the brother sister or no grandparent, no one has any kind of diabetes history. How can my child develop this? He was all fine that 15 days back. हमें रूम स्कूल जाता है, सब करता है, खाना पीना सब अच्छा था, एवरीथिंग वाज गुड टिल लास्ट 1 month, but suddenly this thing has happened. How it can happen to me? And there's a big kind of
No one
stress
has
in the
type till
family.
last
So
1 month,
first thing is
but suddenly this
acceptability.
thing has happened.
So we have
How
to
it
tell
can
them,
happen
and
to
then a
me?
lot of
And
then
there's a big
questions,
kind
ifs
of
and buts comes in
no
the
one
family's
has
mind. The
type
family
till
क्या
last
बोलती है,
one
first
month,
thing is
but suddenly this
acceptability.
thing
Is
has
that why
happened.
it
So
should
how it
happen?
can happen
And
to
then a
me?
lot of
And there's a
why me,
big
why
kind of
me is one of the big
no
questions
one
families
has
they
type
ask
till last
ask
one month, but
and
suddenly
it
this thing
becomes
has
some why
happened.
it
So
should
how it
happen.
can happen
And
to
then a lot
me?
of
And there's a
why
big
means
kind of
acceptability
no
becomes
one
there.
has
They
type
ask
till last one month, but
and
suddenly
or
this thing
Archana
has
like
happened. So how it can happen to
consultant
me?
for me.
And there's a
And then we
big
have to make
kind of
them understand that this is a kind
has
of an accident. When you started from home, you are not sure that you know never presume that something will happen on the road. It's more of an accident suddenly comes, and then it has to be accepted for. So one thing is acceptability. Once they accept, so we have to tell them that this how it happens. There are beta cells which secrete insulin, which controls your blood glucose, and a lot of basic science behind it. You have to also tell them that this is not a diabetes where you will go for some baba kind of thing, or some powder kind of thing, or jadi buti kind of thing. It is a diabetes where your insulin is not being prepared and not being produced by your pancreas or beta cell, and now they will need insulin for the whole life. But the most important positivity which Risham I will tell you is Archana will also will agree on this, is you have to tell them that this is the only ailment. I don't call it a disease, I call it as a condition. It's not a disease, it's just happened.
Hmm.
So It is a condition where you have 100% treatment available. You have 100% treatment available. If you take insulin properly, you can have a normal life as that of a non-diabetic person. So the most important thing at this, most of the 80-90% of these children are being diagnosed below 20 years of age, and many of them between 5 to 15 years of age. So 5 to 15 years is the peak period where there is, no one expects such things. Sometimes पूरे गांव में एक ही बच्चा रहता है, और वो एक बच्चे के लिए फिर पूरा stress, and there are a lot of diabetologists in our country. Every house has a diabetologist, every neighbor is a diabetologist, every dukan wala is a diabetologist, and every social worker is also diabetologist. So they go on teaching these people, and sometimes confusing the families. So family support in such situation is to make them understand that this is an accident. You have to accept it because it's going to be the lifelong situation. You have to also make them understand that insulin is the only treatment in the world. And if they take insulin, though it is in the form of injection, but injections are the most painless prick in the world. The needle which is used in the insulin series, which is in human use, is the finest needle in the world. आप उसको 4 बार भी प्रिक करें तो हम लोग तो अपने ऊपर प्रिक करके बताते हैं कई बार कि देखो कुछ लग रहा है क्या. So the only difference between a person with type 1 diabetes and non-diabetic is the insulin is not there in their body, and here we have insulin of our own insulin. So बाहर से insulin ले लीजिए, and you are able to have normal studies, normal adolescent, normal adult life, normal studies, your job or whatever profession or your career, normal job, except हम आपको प्लेन का पायलट नहीं बनने देते हैं और हैवी व्हीकल का ड्राइवर नहीं बनने देते हैं. ये छोड़ के दुनिया के कोई भी जॉब आप कर सकते हो. सो एनी जॉब यू कैन डू, एनी प्रोफेशन यू कैन चूज, and you can have marriage, and और बच्चा हो गया और बाद में retirement. So you can practically, and next question comes to your mind is, अब इसको हुआ तो इससे शादी होगी तो इसके बच्चे को भी तो हो सकता है. That's another stress. So हमारे भारत देश में क्या है, 2-3 चीज बहुत इंपॉर्टेंट है. पहला कि उसका शादी, दूसरा उसका बच्चा, and career rather comes third. So this is again important, especially when it is a girl. So becomes another negative points in their mindset. So we have to make them understand that they can have everything normal if they control their blood glucose well, and if they control it well, they can have. So once they accept it, then the whole team, including mother. Now Archana has a wonderful job in educating their mothers and making them as educator. If some other mother comes, and we have a group here, JDPI, Juvenile Diabetes Parent Organization of India, and they are being created as an educator, and they also come and educate and empower these people and make them understand that don't worry about it. मेरे बच्चे को 12 साल से, मेरे बच्चे को 20 साल से है, I am doing this, तो आपको भी चिंता नहीं करनी है. तो ऐसा स्ट्रेस आता है, and we have to educate them, and we have to give them some basic knowledge. Also involve such people, some of the role models, they come and they also educate such people. So we have in our system, in our clinic, Archana, we have a system. If someone fresh, newly diagnosed type 1 comes, तो वो family को हम लोग, most of the time they come with ketoacidosis and they get admitted. तो जैसे ही 24-48 उसमें कीटोसिस वगैरह थोड़ा सेटल हुआ, सब अच्छा हुआ, तो we call other parents to meet them, other children to come and meet them and make them share their stories, and then acceptability becomes very easy, and then this group becomes a very big support group for them. And such groups are available everywhere, whether it is Nagpur, whether it is Aurangabad, or it is Mumbai, Delhi, or anywhere. So family stress is certainly there, but it need to be taken care in a very, very positive mode. और घर में हमेशा सबको बोलता हूँ, खासकर ग्रैंड पेरेंट्स के मामले में, पेरेंट्स दे डू अंडरस्टैंड, बट ग्रैंड पेरेंट, अरे अब बच्ची को लेना पड़ेगा इंजेक्शन, ये जो बेचारापन है, that should never come in the discussion. You have to make them understand that you are not bichara, you are absolutely perfect person in the world, and don't take diabetes as a disease, take it as a kind of condition. I feel very small question, but unfortunately I have taken it a very long time. Over to Archana and Resham once again. Thank you.
Yeah, so as rightly pointed out, acceptance is really, really important. So Dr. Archana, anything you'd like to add to this?
Oh, I think that's perfect. I would just like to summarize it in a way that we stick to the science, which will not repeat. So explaining the science, as Sir said, is very, very important. And second is the peer group support. I think that is two very big questions. And as long as we stick to these two pillars, then rest everything counseling. And it takes time. We also have to understand we cannot give the whole load on the first meeting. It has to be a staggered time till they accept. So we can't say, why don't you understand? It's going to take time. So we have to be very patient. But I totally agree with everything that Dr. said.
Okay. So, Dr. Archana, how do you determine the appropriate insulin dosage for a child with the type 1 diabetes? And how are different insulin delivery methods available for the children? Like, what are the different insulin delivery methods available for the children? Like, how do they impact their daily life?
Right. So I think I'll take the second question first and then come to the first one. So basically, insulin needs to be delivered subcutaneously, which is the fat layer between the under your skin that you see. Now, for subcutaneous insulin delivery, there has to be a very small needle. Currently, although inhaled insulin, like an inhaler, has been formed, but it's not available to us to take as a regular thing. We do not have, all experiments have happened for pills, patches, creams, but nothing is currently available. So first bottom line, it is a kind of a injection, if you could call it, a prick that will have to happen. Now, it can be a very simple one, such as a insulin syringe. Insulin syringes are of many types. They are the cheapest type, cheapest available. So that is something which will be available in any medical shop. So that's very important. And even people who have the best advanced delivery devices should always keep insulin syringes with them, because in case of emergency, case of breakage, in case you forget your bag or something. So a very simple thing which is always working is an insulin syringe. Now, one very important thing people should know, that insulin syringes come with different strengths. Right. So it can be a 40 IU syringe or a 100 IU syringe. So whenever a doctor prescribes or a medical shop gives, a pharmacist gives, or an educator tells, or a parent sees, they must know which strength to match with which insulin they are taking. So the first thing is a syringe, which is simplest. It costs around 5 to 7 rupees. You can just fill up the syringe and take a small prick. At this time, device, along with the device, it's very important, and we'll talk about it later, not in this question, but that is, they should know about the insulin injection technique. So it's not just about what to use, but also how to use, where to use, how to change the spot. We will talk about that much later. So that is the first thing, syringes. Now, the next level that has come from syringes is it's like a pen. It's like a writing pen. Now, it has a pre-filled cartridge and a very small needle on the top. So what happens when you use a syringe is you have a bottle and you have a syringe. So every time you prick, fill it up, and then you take it. So it's one prick here, one on the abdomen or wherever it is being taken. In a pen, there is a needle which is attached to the top, and there is a cartridge like you have in a pen, you have a refill similarly. So that becomes very easy. There are many advantages of using the device because it has a rotation knob at the end, because of which you can have a very exact dose. That is one advantage. Other advantages, the cover of the pen is heat insulated. So it can be carried with them anywhere. Third, because of its convenience, you can take it to school, you can take it to travel. So again, it's 100 IU, accurate dosing, small drop size. So all these advantages are there. The difference would be, it will be, for the same insulin, it would be a little more expensive. It won't be too expensive. If it is the same insulin that we are using, between a syringe and a pen, it would be a little more expensive. So that is the second thing available. And third level, which is available, is an insulin pump. Okay. Now, insulin pump is something, it's an electronic gadget which has a small reservoir where insulin can be filled. The beauty is it has a small cannula which can be attached usually to the abdominal wall, but elsewhere as well, which can be changed every 3 to 5 days. So on an average, any child living with type 1 diabetes will take 4 to 5, sometimes even 6 injections in a day, but usually it is 4 to 5. So this takes away the need for pricking 4 to 5 times. That is one. There's once in 3 days. But pump is not important just because it takes away the important number of pricks. It is very important because you can give very accurate dosing. Because when we give with the injection devices, we are able to change what we take with our meals, but we cannot change the rate of our 24 hours insulin. That you can change with a pump. So why am I emphasizing this? Because many people think, "Okay, I have money, so let me buy a pump." So just buying a pump is not a solution. You have to learn. So all three things, then once you have these three devices, right, which range from a 10 rupee syringe to a maybe 250 rupee pen to a minimum 3.5 lakhs pump. Okay. So if we go into this range, money is just one of the criteria, but important part is you should know what to do with it. I mean, whether it's the humble syringe or an expensive pump, the best of pumps which come with monitoring is around 6 lakhs, 7 lakh rupees. They're wonderful, but you should know how to use it. And here comes the question which you first asked, that how do you adjust the doses? So it's a triangle, whether it's a baby, a child, or a thing. One is sugar monitoring. The most important thing in part of diabetes management, type 1 diabetes management, is actually knowing what your blood sugar level is, right? Because dose comes later. Where am I right now is very important. Second is being able to understand how many carbohydrates are there in your food. So when you have when you're armed with two things, when you know how much carbohydrates are there in your food, when you know that this is my blood sugar, then there are ways of calculating. There are formulas called ICR, ISF, and there are many, many ways which we teach. We teach the simpler rural versions to the illiterate population. We teach a little more complex to the people who can understand. And we do the final, very intricate ones, which can use, to the people who can understand with advanced care. So there's a whole journey, which depending on the understanding level of the person you're delivering that care to. But what is very important is that we can do this for all. So we can use a syringe, a device, or a pump. But most important is you check the blood sugar. You're able to understand the meal that is going on. Of course, there are many other factors which will influence the dose. Simple things like being sick on the day, not being able to eat, playing a lot, traveling. So all those factors we teach, but on a very, very basic level, your blood sugar level, your actual food content, carbohydrate content of the food, and then there's a formula, learning that formula. So in our clinic, we give a grid and they know how to do that. So then you have the correct dose. So that's how it is done. But it's a lot of education. I mean, it's very difficult. We learned it. We're still learning. And then our educators learn it, nutritionists learn it, and the parents learn it, and the children themselves learn it as they grow up because they are traveling, they're going to college, they're going to school, etc. So it's a lot of learning, and that's how it's done.
So, Dr. Archana, that was actually really helpful. So, Dr. Sunil Gupta, would you like to add anything to it?
I feel Risham's important thing Archana has pointed out is that this insulin pump is not a luxury.
Yeah.
You have a Maruti car and now you're going for having BMW or Merc. It's not like that. So you have to first understand it should be a requirement and a need. Of course, every type 1 diabetes, certainly if they use pump is going to be the best as far as the global data is concerned. And people have got wonderful control of blood glucose before and after the pump. But we also have a dark side of it that many of the times these patients, they purchase their pump, but they can't do well because they have not been empowered with the good quality knowledge to use the pump. So always one should be prepared mentally to have a person who is motivated, acceptable, positivity in the whole system. Like you have your mobile, you can keep a mobile of 20,000 rupees, you can have a mobile of 1.5 lakhs rupees, but if you're not using those facility in the mobile, it has no use. I feel 20,000 is good enough. So this is how it should be.
Yeah. So as we're talking about preparation, Dr. Gupta, I would like to ask you that how can parents and school work together to ensure a safe and supportive environment for children who have type 1 diabetes?
So most of the people in the country or across the globe, those who are involved in the care of type 1 diabetes have got a wonderful system. What they do is that we usually issue a simple letter to the principal mentioning that this is a type 1 diabetes, which and a little brief about type 1 diabetes, and these children should be they need to have a regular insulin therapy 4 times a day, and out of them one of the prick might they need to take, 1 or 2 pricks might need to be taken in the school, and they need to be having meals every 3 to 4 hours. They should be allowed to take glucometer with them and the insulin pen. And many of the times, because they don't have a cool chain available, so we ask the parent to take extra insulin, keep in the fridge of the principal. And most of the children, the principal, they allow them in the office or the side, the lecture hall room or somewhere, and they ask the children to take their insulin there. And then, of course, insulin also remains safe there in the refrigerator most of the times. If you don't have a refrigerator, then we also have other options, which I'm not going to go in detail. But small school, sometimes you don't have a fridge. That time you can use the cool bag, because a cool bag has a ice bag, and this ice bag they can just keep it, and for 12 hours your insulin remains on the normal temperature, so should not be worrying about it. So daily they can even keep that. So school, usually we discuss, most of the times we go personally and meet the class teacher and the principal, and we try to convince them for such thing if there is some resistance of the school management issues. But then 99% of the time they accept all these things, and things have not changed. Now, even at this time, for the first time possibly in the history, the government of India has come out with the guidelines for type 1 diabetes. It has also come in the print as well as the social media across, that they are allowed to take the meals, the needles, the syringe, as well as the some eatables for during the examination, because sometimes you start the exam at 10 o'clock, but you need to go there before 9. You have to start at 8 o'clock from home. So practically it's a long hours, that, and then the three hours new paper. So it comes almost 6 hours, or almost more than 6 hours sometimes, to manage, and such patients might end up into hypoglycemia. So they are allowed to take. So now government of India has issued the guidelines for type 1 diabetes, and it's a very positive thing. And because of all this, education system now is well aware of type 1 diabetes, that there is such thing exist, and there could be at least one child, or sometime one or two children will be there in some of the schools around. And now things have become easier versus what we faced in 30 years back, almost 32 years I'm practicing now. But we have seen that earlier there are a lot of resistance. They admission nahi dete the usko, यानी निकाल देने का काम आ जाता था कि no, we will not be able to tackle this. But now you teach the class teacher, the attendant there. There are a small group of children who are very close to these children, 3 4 people, 3 4 children who are around, close friends who was going with them in the auto, or the rickshaw. Even they are being taught about what is hypoglycemia, what is high blood sugar, what is low blood sugar. If they have this symptom, please manage it in this way. So these are some important. So what Archana has also insisted, even I insisted in the early stage, that what matters is education and empowerment. Educating the science in a simple language which can be adopted by each and every bacha, their parents, the support system of the school, the children around, neighbors, attendant, whoever is there around, auto driver, everyone should know about it. And once they know and they're being taught about it, things becomes very simple. So support system is need to be more aggressively. Still a lot of things to be done, because very few people are doing on these lines. Many more such things are required in future.
Yes, so great points, Dr. Gupta. So, Dr. Archana, I like to ask you that how do you manage insulin administration in very young children who may not be able to communicate about their symptoms?
So mostly children will not communicate about their symptoms. It is the parents who have to understand sometimes even symptoms which don't seem like symptoms of diabetes. As Dr. Gupta mentioned earlier, that bedwetting, right? A child is crying in middle of the night, excessive hunger, thirst, urination, even being listless, being very tired. And of course, it could be a dangerous sign to be very breathless and not thriving. So all these things are usually a child is unlikely to come and say, I have something so and so. So that is why a very high level of awareness is needed. And as we were talking about the school program, probably that is the place where these symptoms should be really taught in, say, parent-teacher meetings or as leaflets. There are a lot of IDF project is there called Kids, which can go to parent, teacher, and child. So if people are aware of the symptoms, then they can seek them out and at least test if needed. So that is in people who are not yet diagnosed, children who are not yet diagnosed. But if they're already diagnosed, then insulin has to be administered irrespective of symptoms. It has to be administered with a very strict pattern of checking in a way that is done in a prescriptive way that has been given by the doctor. And what variations can happen are also taught to the person. For example, a correction dose may be needed, an extra dose. So those symptoms are taught to the parent. If this happens, check the blood sugar. If blood sugar level is above 250, check the ketones. So the ketones is another thing that people have to be able to check in the urine at home. And if that is true, then this is what is to be done. So all this is taught. Again, a very major part is education. And how do you inject the child? I think the younger they are, it's easier actually. My experience is the smaller they are, imagine a 1-year-old child who has been taking insulin injections from age of 1. Gradually, it becomes like brushing their teeth. And, it's only when they become teenagers that they realize, okay, we can rebel. This can be held as a bargaining chip against our parents. Otherwise, the younger they are, the easier it is. Of course, it's difficult for the parents. Children, giving them insulin, checking their blood sugar, rarely say no. And even when they do say so, it is usually a kind of a mental block, which goes away when they're with peers and when they're accepted. The block comes to parents of small children, because to prick your own baby 4 times a day with insulin and 5 times or 6 times, and younger they are, the more you have to prick. Because it's unpredictable. A 2-year-old child, you can't have a fixed food regime. They're grazers. They will eat. They want a biscuit after their meal. And what do? And sometimes they just will grab and eat it, or they throw a tantrum. So these little ones are really difficult to manage. But frequent checking is something which helps. And then insulin pricks. So the mothers and fathers have to be really, really trained, comforted, counseled. Children are fine. They do well. All children are easy to. So give me a child any day, but give me a mother and it's a tough calling to do.
I think that is something new that we knew from the session, that actually child is pretty easy to manage, but the parents are, yeah. So, Dr. Sunil, in terms of technology, what advancement have been most beneficial for monitoring and managing type 1 diabetes?
Resham, as first thing, I should really appreciate on this endorsement of one important thing what Archana has said, that our small children are better to manage than the adolescent children, especially adolescent. But when they're less than 5 years of age, it becomes very easy. And earlier, the diagnosis is easy to manage because they understand from the day one and in the early stage. So your question, if I come back, is on technology. Technology certainly is good, and now we have earlier we had different kind of syringes, but now you have the pen. As I told you, the finest needle in the world in human use is insulin pen. So pen is one thing which has made the insulin basically painless, the prick. Second is, of course, we had some discussion on insulin pump when it comes to technology. So insulin, there are a lot of other things which she just had passed on the remark, but I don't think I should go on it because it's not available in India when it comes to insulin patch or inhaled insulin all. But you have these insulins which can be given with this pen. But even if you have if you can't afford to go for insulin pen and needle, even syringes are also quite good and quite stable. That's one thing. You have insulin pump when you use, then you have it's called as artificial pancreas. Artificial pancreas means when you eat food, suppose if you have been given a cup of, say, if you take a cup of tea, and the moment you take the first sip, within 2 to 3 minutes, the insulin is secreted from your beta cells, and it controls your blood sugar continuously, whatever you take extra meal. Now, let me take you, Resham, to our children who are listening this. Insulin is being secreted in 2 forms. One is the basal insulin, which is a 24, it is a normal person, including me, you, Archana, everyone, Himani. Now, we take the insulin is one is a basal insulin. Whether you take the meal or whether you don't take the meal, insulin is continuously being secreted, and it controls your fasting blood glucose. The blood glucose being maintained throughout. The moment you take some meal, there is extra insulin secretion. That's called as prandial insulin.
Okay.
So you take a cup of milk, it will be secreted. You take full lunch, it will the insulin secretion will go. Depending on the quantity of the food, the carbohydrate content, their glycemic profile, the blood glucose, the insulin is being secreted, and in normal person, it try to keep it in a normal range of say 80 to 140 or 90 to 140 in a particular range. It keeps it in normal individual. Now, what happens in diabetes when you try to treat a person with type 1 diabetes, you have to practically manage the basal requirement and the bolus requirement. So when you give insulin, with every meal, you have to take 3 pricks minimum, breakfast, lunch, dinner, and sometimes at 5 o'clock also we give it snacks. So it is 4 pricks for boluses and basal insulin once in a day or sometimes twice in a day. So you try to keep this, but they might not every time will be able to control all the peaks and the full basal requirement. And that is how we use pump in some patients, those who are affordable when there is an indication. And this pump will give you both the basal rate, and basal rate can be actually customized depending on your CGM. There's a sensor which is called as continuous glucose monitoring, which gives you every 15 minutes reading for 14 days. There are other sensors where they give every 5 minutes for 7 days. So the sensors will guide you that how much is the requirement at particular time, at morning at 7 o'clock, afternoon 12 o'clock, evening 6 o'clock, or midnight and 2 o'clock in the night. So every time what is the kind of glycemic profile you have, on the basis of that, your pump can be customized. And now you have an automated pump. You have an automated basal requirement being calculated by the software. Once you put the carbohydrate content of the food, suppose if I am having idli, you just put idli and the carb content you can calculate. That's called carb counting. I feel Archana will cover that. And the moment you have a carb being counted, that this much amount of carbohydrate is entering in your body, the insulin requirement of that carb content of that calorie being calculated by the pump, and it automatically delivers the bolus also. So now the newer pumps, which is of course costly, but they even do this. But when it comes to technology, I should cover it. So they have basal, they have even bolus being calculated once you have a 365 days sensor with you. Is second. Third is in technology, now you have sensors. I told you that's another thing which is important. Then there are multiple mobile apps now available for the carbohydrate counting, for your insulin calculations of the insulin, for having a different kind of management profile to become compliant for the insulin as well as for the diet. If you are exercising, you just have to put how much you are exercising and how much calorie you burnt. All these things are now gradually being, and it's there in your simple mobile. And insulin pump, then there are some glucose watches which has been approved but not in India. So you can just because the glucose being measured from the sweat gland, from the sweat you have. So such many more things are going to come in future. A very promising sensor which is going to be implanted somewhere here in the arm, and that will have its life for 6 months, or now they are planning for even more. So that now it is only 14 days, but in future, if you have implanted sensors, you will have the blood sugar measurement will not be through the prick, because sometimes this prick multiple times. We recommend that minimum 4 to 6 pricks per day for the monitoring. At least minimum 2 per 4 to 6 per day. Every pre-meal, at least you should do it 3 times a day. So these pricks can be avoided if you have such thing, but it is again under trial, and some of the places it has been approved. So such much more things are coming. If I've forgotten something, I feel Archana can cover in technology. But sensors and the devices and the pumps, these are important things. And yes, we have some advances now coming up in type 1 diabetes, where this diagnosed very, very early. And there's a drug which has been approved in type 1 diabetes, or sometimes a early stage of type 1 diabetes, and even there is a small phase of pre-diabetes in type 1 diabetes. Those who are high-risk patients, their GAT65 antibody is one of the tests. Their C-peptide is normal, but the GAT65 antibody positive. Some sibling has type 1 diabetes, and the other sibling is being tested for it. If it comes positive, so there is some drug which can be used to postpone the development of type 1 diabetes. That will be for prevention. But this is again has been approved recently in US FDA. We have to have our own Indian data for all this, but it is still very preliminary to be used continuously at this juncture of time. Very early stage of this recent development. Archana, over to you.
I think that covers the entire new things that are available. I would just like to drive home a point that if there are limited resources and one can invest a little bit. So the first thing we would recommend to save for is a CGMS, the continuous glucose monitoring system, because that really gives a wonderful insight. And when you're pricking 3 to 4 times a day, you do not get to know what is happening in the night, when you're playing, when you're in school. And that is going to help take the right doses. So the first investment as a first next level would be CGMS. And then, of course, as per affordability and motivation would be a pump. And then, of course, all the technology.
And every type 1 Archana should be going for at least, like you do HbA1c once
at least
once in 3 months you should have CGM.
Agreed. If they cannot do a continuous forever, then at least do it like a diagnostic tool once in 3 months, so that whatever is happening, one can know, one can set patterns, one can see the responses, because each individual is different. And if possible, we should aspire, I think, one day in the country, every child should be at least on CGMS.
Yeah, I think
this platform, Resham, I can just tell people that those who are into the IT industry, if we can stimulate them to have our own Indian sensors.
Indian CGMS, yes.
Now the things are that the sensors are costly. That cost you around
4,000 rupees for 14 days.
Or even that the other one is 4,500. So almost 5,000 rupees.
8 to 9,000 rupees per month for monitoring.
So, which is very costly affair for an Indian patient. So if they come out with some good sensor technology, if they develop, and the sensor should be available like maybe 200 or 300 rupees per sensor.
I know, we can have rockets, sir. If ISRO can do a
that's what I'm
we
saying.
cannot have sensors from India.
We should have
our
own development. Unfortunately, we doctors are very poor in such research in technology, but we can certainly give a clue. And those who are listeners here, we stimulate them. We try to sensitize them that instead of getting sensors from other countries, if we can develop COVID vaccine, which can rock throughout the world, why not to have these sensors for diabetic children? And it will not be only used for type 1, can be used for anyone.
Exactly.
And they should be costing less than maybe 200 or 300 rupees should be good enough. And every month they should use it. And even if it is so cost effective, it may run for 365 days. So something like this should come up now and will help our people. And this 3 months again, don't quote us. This is an expert advice. No one has recommended 3 months.
Just a suggestion.
Continuous. Everyone says every month. Some of them say every 2 months. But me and Archana are a little conservative because we see the population where they even may not afford even having insulin purchasing sometimes. So we are treating some of the very compromised people in the society, whether it's Nagpur or Aurangabad, and unfortunately it's not being insured. So that is why people might not afford to go for it. That's why we say at least like HbA1c do minimum 3 months, right, Archana? It's more
absolutely.
There's no official recommendation from anybody that how much it should be used, but it should be used frequently.
Ideally, every day, every time. But
ideally,
365
days. Ideally, 365 days. That's what it is.
Yeah. So anyone from the audience is watching this, and they should definitely take up the recommendation, and we can obviously work on this. So the next one is actually for both of you, which is doctors, what strategies would you recommend for helping children cope up with the emotional aspect, something which we ignore at a lot of levels? The children who are living with type 1 diabetes, how can they cope up with the emotional aspects?
I'll go first. So I think the first important thing is we'll start with the language we use, which means the doctor who diagnoses them for the first time is we don't label them, right? So it's, I think, a very big impact happens from the first doctor they meet or the first treatment that they receive, because then when they say it is so scary, people use fear techniques, and that's where the emotion comes from. If the first doctor you meet explains to you, okay, now your beta cell doesn't have insulin, let's take it from outside. So what do you want to become? Okay, you're going to become a cricketer. Oh, great. Wasim Akram is a cricketer with type 1 diabetes. I mean, if the first conversation happens as a matter of fact, then probably the whole roller coaster of emotions doesn't set in, because the trauma unfortunately happens in the doctor's clinic, where the doctor is also trying to tell them it is serious, it is scary. And people tell them because of diabetes, you'll lose your kidneys, your eyes. So all that fear, using fear as a motivation is the first thing which every person in the healthcare community has to stop. There is an age appropriate response to everything. You do not do this for little children. You don't do it for young people, because there is an age at which people can think about the future, not at 5 years of age, not 10 years of age, not even 14 years of age. So that fear is not to be used. That is the first thing that sets it. Second is, as I said, the language you use. The moment, as Dr. Gupta also mentioned, you start saying, "Arey bechara," so it is not just the doctor, even your receptionist. So how do you talk about a child who is living with diabetes? We don't even say a diabetic child. That is a language which is not used, because that's a label. The person is not diabetic. Person has diabetes. Person has amazing another 100 things, out of which has one little element which is called diabetes. So when you change the language, automatically mindset changes. The third, and very difficult for Indian society, is not to be judgmental. Right. So in a society, and I'm very critical and candid about this, is because I feel very strongly about it. In a society that judges color, size, shape, it's very difficult for them not to judge someone who is taking 4 to 5 insulin injections a day. Right. So that judgment, we have to stand up to it. If you let it go, then it's going to percolate. So parents have to come out, literally come out, and not hide it. Just imagine what happens as an emotion. When you hide something, the child gets an indirect message that there is something wrong. Because you don't hide good things, you only hide the bad things. So the parents may do it for whatever good reason. I mean, intentions of parents are always right. But the impact is a very subtle undercurrent impact, that it has been hidden. That means I've hurt them somewhere. There is something wrong. And last but not least, I think for emotional support groups are very important. Peer support is something that really helps to open up emotions. Because when you see that every child who has come to me till date has broken into a smile, a big wide smile, the moment they saw, you also have it, you also have it, you also have it, okay. And suddenly, I mean, it's not as if their diabetes becomes less, but they see 100 other people dancing away with type 1 diabetes, and they're like, okay, it can't be that bad. So peers, meeting peers, so doctors and clinics and educators should actually, like Dr. Gupta and I, to do it as a part of our protocol. But even others, even if they have only 10, for example, patients, I mean, we don't even call them patient, but they have 10 families who have a child with diabetes, call them on the same day. See to it that 4 of them meet each other casually outside. Plant it, make it happen. So that peer care or peer sharing, these are the 4 pillars, I feel, on which we can make a good start on emotion. I mean, it's an endless topic. Mental health, emotional support is the biggest challenge after we have taken medical care. But at these 4 levels, we can make a good beginning, I feel.
Yeah, as rightly pointed out, Dr. Gupta, something that you would like to say?
I feel fully agree with this. I feel she has covered everything. The only thing, sometimes it happens, you are trying to teach science to the parents. Child is trying to means many of the times the children who are maybe around 7, 8 years or so, They do understand everything. They do understand little science also. But what happens is sometimes you say, "Acha bachcha tum bahar ruk jao," means बच्चे को बाहर रुका देते हैं, and then you discuss with parent. That becomes a very sad situation in the mind of a baby, or of a child with type 1 diabetes. He presumed that there must be something bad or something wrong happening with me, and that is why Dr. Gupta or Dr. Archana has asked me to sit outside, and now they are talking only with the parents. So we should always avoid doing so. Even if you have something confidential to be told to the
All
people,
them separately.
always do it separately. Let that meeting be over. Let them go out, and then again after sometimes when they are alone, that time you can do this. But never ask anyone to go and sit outside, because you have to have some different, especially in the first meeting, is utmost important, Archana. And the moment they say na ki ab kya hoga, it is so. And she also pointed out the receptionist, the nurse sitting there, the dietitian
Everyone.
in the clinic. Everyone should be with the positive. Oh yeah, good. Don't worry. Arey yaar, dekhna main sikha deti hu. See, this is so simple. See, I'll pick it on myself. It's very simple. And peer group, of course, everyone should do that. Nice, Archana. I appreciate it.
Yeah, so Dr. Gupta, I would like to ask you that for parents worried about hypoglycemia, what are the key signs and symptoms they should actually watch out for, and also how they should respond, or they should respond on the same?
See, hypoglycemia, not necessarily what is written in the book will be presenting to you. Usually, in a person, it may present with hunger, sweating, irritability, the sometimes loss of attention, in very severe cases, tremors. Usually it is the hunger. तो भूख लगेगा, पसीना आएगा, ट्रेमर्स जैसा हो सकता है, irrelevant talk, irrelevant behaviors, someone who's always you should remain silent, suddenly start talking, someone who's always have a talkative kind of nature, suddenly stop talking to you. So anything like this, any abnormal feature which you or the attending person has never seen in the past, could be a sign of hypoglycemia.
Okay.
So this is one thing which everyone should also try to learn their own hypoglycemic symptoms. This is utmost important, and that is why monitoring becomes utmost important thing for detection of the hypoglycemia. Now, there is also one thing that hypoglycemia, when it occurs, you have to first monitor the blood glucose. If it is low, or if you have a symptom, then you should replace it with 15 gram of glucose. So it's called as rule of 15. Rule of 15 is just you can give 15 gram glucose, wait for 15 minutes, and again check it. Now, this could be less for smaller children, but this is good for even adolescent children. This rule applies. Second is this about the treatment part. We have to see for the causes of hypoglycemia. I told you the symptoms. Sometimes it may present with coma. Sometimes it may present with seizures. It may present with sudden cardiac arrhythmias in adult people. So I'm not going too much into detail of it, but two important things for type 1 diabetes. One is, if you have a hypoglycemia, or if you're having repeated hypoglycemia, you have to first see what is the precipitating cause for this hypoglycemia. So next time it should not happen. And these precipitating causes could be if someone is taking 40 IU insulin, the 100 IU insulin with 40 IU syringe. One. Second, if you are taking insulin, if you are taking the regular insulin, whatever is been given to you, but if you have done extra exercise that particular day, आज मैंने football खेल लिया, आज मैंने मैदान में cricket खेल लिया, otherwise I am not regularly going for it. Such things. If you have delay your meal by more than 3.5 to 4 hours, then also you can develop hypoglycemia. If you have taken not enough food, what you usually take, and if you take the same insulin doses, then also it can cause hypoglycemia. So first is suspect it, diagnose it, treat it, and then try to assess the exactly what happened, and this should not happen again. So prevent it for the next time. There's one condition which is called as hypoglycemia unawareness. Unawareness means even if your blood glucose is going below, usually it is below 70, you'll start getting tremors or some hunger pain or sweating, and you uneasiness, and you might take something. Acha, mere ko hypoglycemia, I'll take something, because you realize. Now, hypoglycemia is also 3 times: mild, moderate, and severe. Mild, that you understand and you take care of yourself. Moderate, you need, say, Resham will understand that someone is developing, then you will just prompt them. Oh, Archana madam, are you getting hypoglycemia? Something like this, she will prompt you, and you need some prompting, but you take care of yourself. But the severe hypoglycemia is, you don't understand, it's the other person understand, and maybe it present with you semi-coma, comatose, and you don't understand, and ultimately sometimes you need IV glucose, I mean intravenous glucose, or admission, or there is one injection called as glucagon, which we usually keep them to keep it in with them throughout, so the year, so that they can this injection is like insulin pre-filled syringe, and this you can just push it, and it will within half an hour, the 0.5 ml for children and 1 ml for glucagon for adults, we can use this glucagon. So there, I was talking about hypoglycemia unawareness, that your blood glucose, we say 70, and documented we say 54. So anything below 70, if it goes, and it usually present with symptom, but in such patient, you will not have the right symptoms of hypoglycemia. आपका शुगर 60 भी हो जाएगा, 50 भी हो जाएगा, 40 भी हो जाएगा, तो भी आपको समझ में नहीं आएगा कि मेरा ब्लड ग्लूकोज लो हो रहा है. So low sugar symptoms are not being recognized by the people with type 1 diabetes, who have long duration of diabetes, especially long duration of diabetes, and if they are not able to control it for a longer period. So it's because of autonomic neuropathy. So such patients should be keeping their blood glucose on a higher range. Because if you have similarity, if you have one episode of hypoglycemia, if you have second episode of hypoglycemia, and if you have third episode of hypoglycemia, recurrent episodes of hypoglycemia will bring down your threshold for recognition of hypoglycemia. Are you getting this? I feel it's not very complicated, Resham, for you. Did you get this?
Yeah, I got it.
You got it. Okay. So repeated episodes of hypoglycemia will fail your system to recognize the next episode of hypoglycemia. पहली बार में 70 पे समझ में आया, दूसरी बार में 60 पे समझ में आया, तीसरी बार hypoglycemia तो 50 पे भी आपको समझ में नहीं आया, blood sugar एकदम कम हो गई, and you will end up directly, when you go below 30, you may develop coma, hypoglycemic coma. So that is why hypoglycemia unawareness has to be recognized. But what Archana has repeatedly said, even in the first instant, I told you, monitoring is utmost important. So go on monitoring blood glucose. When you put CGM, what she told, that monitor blood glucose every 15 minutes for 14 days, in that you can really make out. Patient does not have a symptom, but have a dip of 40 and 50s during monitoring, and that can be recognized, that can be seen. And then in such situation, you should suspect it. So hypoglycemia is one thing. And another very important thing, when there was some message while discussion that you should learn the injection technique properly. Now, when you're taking insulin with syringe or the pen, you are supposed to rotate it regularly. So proper rotation of site is must, and you should avoid using insulin syringe for more than 3 or maximum 5 pricks with one needle. If you are reusing the needle for multiple times, and if you are not properly rotating the insulin injection site, either in abdomen, thighs, or anywhere you take it, it is likely that if you take repeated insulin at the same site, you will develop a condition called as lipohypertrophy. There will be a swelling of fat tissue, and that place becomes painless. Means very less pain when you prick it. And because it does not cause pain, a child will continuously go on taking insulin at the same site, because it is painless, liposite. But that particular site, actually the insulin absorption get disturbed. You will have a lot of hypo and hyper activity. So we have done wonderful trial where we have this called as lipohypertrophy, and in short we call it lipo. So we have done a trial on lipo, where a person has taken insulin, say this is a lipo site and this is a normal site. So they have taken insulin first 7 days at the lipo site, next 7 days at the normal site, and we have seen there is a lot of fluctuation when they take the insulin at the lipo site. So one should always get it inspected through the educator during ideally each visit, but if not, at least once in 6 months, your educator, your treating doctor should see the site of the insulin injection, whether they have lipohypertrophy. In Indian children, the prevalence of lipohypertrophy is almost to the range of 50 to 70%. In our own data, it was 68.5%. So it is very high, provided you see for it. And if you don't see it, such hypoglycemia episode will certainly increase. When you take it in lipo, blood sugar will remain high. Doctor will go on increasing your dose. The moment you shift it to normal, it will go down or there will be hypoglycemia. So this is called as glycemic variability. So more of a high and low are more dangerous for the blood vessels and further complications in future. So try to keep stable blood glucose throughout, even if it is little on higher side. If your doctor is allowing you, maybe around fasting around 1 instead of 110, you can keep it at 120. Postprandial, if not 140, at least 160, at least 180. Younger children, even 200 is acceptable to you. HbA1c, we say 6.5, but even 6.8, 7, and sometimes 7.2 is acceptable. But these fluctuations are sometimes more risky and more dangerous, and glycemic variability should be avoided by everyone, every type 1 diabetes is. So you have asked me for hypoglycemia, but I also covered glycemic variability to some extent, because lipohypertrophy is one thing. They should, like you teach people with for the breast cancer people, they teach you to palpate your breast and see for any nodule. Similarly, all stakeholders of type 1 diabetes children should teach their patient how to palpate and how to suspect lipohypertrophy and amongst themselves, so that once they teach them, then possibly we'll be able to prevent developing such things in such a large number of population of type 1 diabetes. I feel you shouldn't, no one has covered it, but we have the highest number of type 1 diabetes in the world when it comes to numbers. So we have a lot of challenges, and I should really appreciate you, Himani, and the whole team for organizing this education program for type 1 diabetes, which is very, very focused and an important group to be addressed for.
Yeah, so I think great points highlighted by you, Dr. Gupta. And like you said, that proper monitoring and constant monitoring is, of course, really important. So, Dr. Archana, I think we like to wrap up the session. But before that, one key message you would like to leave for the parents about managing their child's type 1 diabetes.
So my key message would be twofold. One is understand the science, do not compromise with the quality of treatment. If you do not have money, there are large number of NGOs in the country that you can reach out to. Even in the remotest of village, do not compromise by taking 2 insulin shots in a day, not monitoring. So always go for the best natural, which is physiological therapy. What that means, 4 to 5 insulin shots, 4 to 5 sugar checkings, learning how to count your carbs. So the entire ideal treatment should be taken by a child, even with the lowest resource setting. And of course, it goes to say with anyone who can afford it and is educated. Do not compromise. If you don't have somebody to teach you, find somebody, find online. There's the whole world out there where people can support you, help you, guide you, and do not compromise. That's my first part of my message. And second part is absolute acceptance. Because if you believe as parents, your children are going to make their dreams come true, your belief will transfer into your children. Because in your core heart, if you don't believe that my son is going to live long, is going to be healthy, is going to live a fulfilling life, of a career and everything else, then somewhere, even if your words say it, but unless you believe it, it's not going to transmit in spirit to your child. So you have to believe, because there are millions of examples today. I mean, people are climbing Himalayan mountains and playing professional rugby and tennis with type 1 diabetes, becoming pop stars. So what is there not to believe? So your belief has to be coming from inside that your child can lead and will lead a great life, and do not compromise on treatment. Make it very, very scientific. So these are my 2 messages for every parent of a child living with type 1 diabetes.
Acceptance, belief, really, really important. Dr. Sunil, your last words to our audience.
I feel Archana has covered almost everything in these 2 messages. But what I can just summarize the whole discussion is you can imagine a table of diabetes management. Table has 4 pillars. One is diet, second is exercise, third is insulin, but the fourth pillar is very, very important, which is being ignored, is monitoring. So these are the 4 pillars. But do you feel, Resham, that pillar is complete? The table is complete?
Sorry, with monitoring?
The
No.
4 pillars: diet, exercise, insulin, and monitoring. 4 pillars. And do you feel the table is over? Table is complete?
Still need the top table.
You need a table top, and that
Yeah.
table top is education.
Education.
So everything includes, irrespective the acceptability, the insulin, the monitoring, everything will happen. Only one thing we do is education, education, and education. That's my final message. Just get yourself empowered with good evidence-based knowledge and try to propagate this to the needy people, to the remotest place where you have type 1 diabetes. And if you do that, I'm sure that no type 1 diabetes will die off or will suffer with lack of insulin or with the ignorance. So ignorance is the only important thing which we have to deal with. It's see, diabetes is not dangerous, Resham. Diabetes is not dangerous. It is our habit of ignorance. Hota hai na, chalta hai na, nahi liye to kya hoga, like this. So it's a habit of ignorance which we need to now target. More you ignore, more you are going to suffer. So sufferings are not because of diabetes. Sufferings is because of your habit of ignorance. So good education, avoid ignorance, become your own doctor for yourself, for understanding the science, for following the things. And of course, you have to have a good coach who should be guiding you, a good quality education program. And don't try to learn and try to become a student of a Google or Google Baba or any other Babas who might not be having the qualified things with them. Because if they don't have, then you land up in trouble. And I still remember, Archana, whether I shared or not, 2 or 3, 4 months back, I got a type 1 diabetes, 11-year-old lady, a girl doing very well since last 3, 4 years, suddenly came to me with severe diabetic ketoacidosis in coma. I said, what happened to this girl? She is doing so well. Her HbA1c used to be in 7.2, 7.1. What happened to her? She said, sir, she has seen a video of a person where they have claimed, one of the Baba has claimed that there is a cure for diabetes, and you do this particular thing, and their diabetes will be cured. And their parents have followed that. They stopped insulin, and she ended up in coma because of diabetic ketoacidosis. So never ever do that. Fortunately, we were happy to save the life of this person, but she went deep coma. It was almost 5.7 or so ketone. So it was a bad thing, and this should not happen with any child in the world, not only India, in the world. So we should have a good education across. And once you have education, possibly all these barriers and hurdles, what we are feeling, or people have, I call it a false barriers. They are not real barriers. If you see reality is simple, accept it, treat it. So you have a treatment available, 100% treatment available. You can live normal life like a normal non-diabetic child or a person. Why do you worry about it?
Yeah. So
Positive things. Yeah.
So as rightly pointed out, that education is the key. So as we wrap up today's session, I would really like to thank our experts, Dr. Sunil Gupta and Dr. Archana, for sharing their knowledge with us and of course with our audience. And thank you to the audience for staying with us till the very, very end. And managing type 1 diabetes in children is indeed a journey filled with daily learning, opportunities, and we learn that you are leaving today's session feeling more confident and informed, and we have gained a lot of the great insights from this session by 2 of our experts. So thank you once again for the audience for joining and being a part of this important conversation. Stay healthy, stay hopeful, and goodbye to everyone.
Thank you and take care.